Thank you, gentlemen. We're here today to celebrate the 15th anniversary of To Err Is Human and Crossing the Quality Chasm. And I was asked to provide, through our committee, a snapshot of current performance within the industry. I personally see it as some real accomplishment. As I look across the industry, we all work down at the sharp end, where the care delivery actually happens. We're not talking about it in theory, we're seeing it every day in operations of our systems. Just to recap, what Dr. Pryor just described at Ascension, striking improvements in patient safety, frankly, has become a bit of a growth industry in many other systems. High reliability organizations are picking up speed in many different places. Dr. Calhoun talked about HEN networks. It was part of CMMI's patient grant program. Other HENs have reported similar significant results. I think of Don Berwick and IHI in the 100,000 Lives campaign. It goes beyond that. Peter Pronavost's initial work on central line bloodstream infection in Michigan has now spread broadly, and you see a major source of patient injury and death that's been massively attenuated, order of magnitude, lower injury and death in many of those settings. Ventilator-acquired pneumonia, the list goes on. I think that it is abundantly clear that patient safety is better than it was 15 years ago. At the same time, we've discovered better ways of appreciating the breadth of the problem. Most of it is invisible to us. Now, just two comments from my perspective. The first is in every one of these instances, there was an organization. Systems seem to require organizations. It's really hard for a single physician practice, a couple of physicians working together to act at this scale, to do these sorts of things. And I see that as a change that's happening within our industry. The second idea, I believe that a large part of it depends on transparency. Two separate IOM committees examined transparency and came up with a very different definition of it than we often see in a public setting and a policy setting. It wasn't ranking physicians and ranking hospitals. It was supplying sufficient information that patients and the clinicians who advise and help them could assess likely outcomes of a treatment decision. That's what transparency meant. And I think that's evolving. I think the biggest change that's going to happen is infrastructure. The IT systems that we have today are not the IT systems that we'll have in 5 years. There's a sea change taking place underneath. Most of our current electronic medical records were really designed to replace documentation with the aim to maximize fee-for-service reimbursement. And then they bolted on some clinical decision support, some true transparency. And what we're seeing is the emergence of new systems that just flip that 180 degrees. So that they're built for a safe clinical environment, and they happen to do documentation on the side. And I think that it's going to represent a fundamental shift in the way that we deliver care and the ends that we can achieve for patients. So with that, I had a few questions just to kick it off. We have a few minutes for questions and answers here at the end, so be thinking of questions if you have them, but I thought I'd just get it started. David, you had a chance to say what you think the future of Ascension is relative to safety. But Dr. Calhoun, what do you think the future is in terms of public hospitals and your own institution? What do you think the next steps are? What should we be pursuing to make it better?
Well, as I said, I do not believe that hospital leaders in general, not just public hospitals, but hospital leaders in general, now just take patient safety and quality for granted. If for nothing else, again, the financial and reputational risk that are involved in not taking it seriously. I also believe, and again, going back to the importance of having a culture in place where event reporting does occur, does take place, and is very much encouraged, because you can't address it, you can't fix it if you don't know about it. I think in these two areas and others, there's been a real sea change. So now how do we take that and move it into the next level? For those of us in the UT system, we're beginning to talk much more with our colleagues at a system level about best practices that exist at other institutions, and how can you take those best practices and implement them within our own hospital. That's occurring on a regular basis within America's essential hospitals and the public hospitals around the country. There's going to be much more of that will, I believe, will be moving to much more in the way of some common standards with regard to these issues. We're seeing it in bloodstream infections, in urinary tract infections, in medication errors, and so forth. I think it is important that we keep things energized, we keep them moving forward, and that entities like the National Academy of Medicine continue to play a big role in this and hold our feet to the fire.
So, thank you. Dr. McHugh, you know, we figure in Intermountain that about 80% of patient safety resides in nursing. It's at a staff level. That's where the action happens. That's where it really takes place. You've first given us a wonderful tool to tell how the culture is doing and how we're really performing. Ask the nurses, which I thought was quite useful. Actually, more comments about that linkage between nurse staffing levels, care environment, and where do you see the future of this going? And first of all, I need to say, it's wonderful that we're actually tracking it. That's a new thing. But where does it go next?
So, and first, I would say asking the nurses is really key, and that means engaging them in leadership. I'll dovetail onto another IOM report, The Future of Nursing, one of the more recent reports, but one of the more popular, and one of the recommendations there was to integrate nursing into decision-making and leadership. And I think that's part of what it means to ask nurses, is to engage them at all levels across all levels of decision-making. In terms of the relationship between staffing and work environment, I mean, staffing it's kind of an easy area to pick on. We can measure it really well. There is a very strong body of evidence linking it to patient safety issues. But importantly, you could throw all the money in the world and add more people, and if the culture and the environment aren't there, you're wasting your money, and there's good evidence to support that. So it's really thinking about having enough nurses and other providers there to provide care, but that they're doing it in an environment that enables them to do so to the best of their ability.
I just wanted to add on, it is critical to have nurses and other staff in the hospital, participants and involved, and again, feeling free to report. We've done similar surveys, and the AAMC has encouraged similar surveys amongst house staff, those young physicians who are in the hospital in the middle of the night, and how free do they feel to report? How free do they feel to climb the chain of command if they disagree with instructions from an attending physician? They are critical, and one of the things I learned was that there was a bit of a disconnect between what my medical staff leadership thought residents felt and what the residents actually report. Very similar to what nurses report. So I also want to emphasize that it's important that our trainees are trained in patient safety and quality, but also that they are engaged in the patient safety movement.
Dr. Pryor, any other comments in terms of the future?
Well, I might respond a little bit to the culture discussion. We've done 4 or 5 now large-scale culture surveys across our organization. The first, I think, goes back to 2006 or 2008 or so, and we had about 30,000 return questionnaires, 70% response rates across the entire system at that time and across all levels. And what we found was that doctors were twice as optimistic as nurses, and administrators were twice as optimistic as doctors. So it's a very potentially useful tool in terms of opening up that dialogue and that discussion. as people begin to see it, because it at least begins to frame the fact that people do have different attitudes and responses.
One of the things I was really hoping that we'd be able to provoke here a bit is a discussion about, is it getting better? There's a measurement issue underneath, it seems to me, but I know that there are those in the audience who might take the opposite view, that it's 15 years on, and they agree with that New England Journal report that it's not. We wanted to open it up for questions from you. If you have a question, please use one of the microphones. Okay.
Hi, great panel. My question is really about, we've been talking a lot about leadership, governance, and even at an organizational level. It was nice to see Dr. Sal this morning as part of his timeline. Slide showed the comprehensive unit safety program that Dr. Pronovost helped develop, and so some of this is at a very micro level, and I think many of us know that culture is unit based, and so I just wondered if you could give comments about doing things at an interdisciplinary level at that unit level, and the importance in improving organizations not only from above but also from below. Thank you.
Gentlemen, maybe one for you, Matt.
I'll jump in there. So, I mean, I think culture certainly does vary at the unit level, and again, part of the asking means engaging. I mean, hospitals, as one institution, is extraordinarily complex with lots of kind of interdependent cultures within it. But ultimately, large-scale decisions, and what we tend to find, certainly from nurses' perspective, for instance, the greatest variation is between institutions, not within institutions. So I think the focus should be at the higher level, but where a lot of the action is, and where particularly some measurement should be taking place, is at the direct care level and at the unit level.
So just to comment on this particular topic, frankly, the HRO movement, the Serious Safety Event movement, is the first process-level, scientifically based approach that I've ever seen in safety that reduced major surgical events. So wrong patient, wrong procedure, wrong site of surgery, retained foreign objects. Oh, the big one's wrong anesthesia, actually. And it turns out that it centers around communications. In fact, we borrowed a fair bit from the airline industry, what's called crew resource management, CRM, at morphed over, but we've had some awfully good work on it. So HRO, as Ascension's been doing, nearly always is about reducing authority hierarchies across a team and having formal structures of communications that obligate staff to speak up, and then a formal way in terms of how you respond. And frankly, it's the first thing I've seen that actually demonstrably reduces surgical event rates. We have the science now. David, I know that's what you do.
Yeah, so we're in Washington, so I have a dream. And the dream that I have is that we would actually have safety systems that would enable us to understand that this is, if we use Reason's organizational perspective, where organizations are a balance between production and protection. And when we make decisions at an organizational level that improve production, we would also be able to understand the impact at protection. And we make decisions all the time in healthcare that have that kind of impact. For example, nursing staffing ratios. And we do not understand at the time we're making those decisions what the potential true impact is on protection or on safety. So I would have a dream that, in fact, while we certainly have to focus a lot of the work on the microsystem and at the unit level and what's happening, we also need to be aware that within the systems and in the environments, because it's very difficult sometimes to create the changes at the unit level if you don't have the right kind of culture and structure in the system.
Hi, I'm Ellen May Carr. I am a registered nurse, a nurse informaticist. I came to Washington to work on safety issues. I currently work on detail at AHRQ, and prior to that I worked at the Office of the National Coordinator. I I'm speaking, though, to you today as a doctoral student interested in error and error reporting. So what I'm asking about is Dr. Burek had talked about error reporting as maybe that's not exactly the way to look at the numbers. But I'm hearing this theme of error reporting from this panel quite a bit. I know from being a nurse and a nurse informaticist that the pace of care has just risen exponentially. And the usability of systems, error reporting systems, is not so great. And so nurses and other clinicians have a hard time taking that time out for that one-off reporting. And I was wondering if you had any ideas around that.
What we know is on the second IOM report, we identified 3 methods for detecting care-associated events. The first was voluntary reporting, which is what you're describing. The second were chart review systems, which is IHI Global Trigger Tool. The third were called prospective trigger systems. Scott Evans actually was one of the real leaders in the country in doing those. We discovered the voluntary reporting system missed somewhere between 1 in 10 and 1, well, they found 1 in 10 to 1 in 100. They missed as much as 99% of all actual injury events. Those other 2 you can automate to a much greater degree. And so I see systems now shifting to more automated detection, and I think that that's only going to get stronger. By the way, it means at a national level, even as I think care gets a little safer, our detection is going to continue to improve, and so how you solve the mix between those 2, it will be really hard to say, are we getting better or getting worse at a national statistics level? So for AHRQ and the National Patient Safety Report, it will still be a hassle along the way, pointing at Carolyn down there. We're out of time, so I'll apologize to the folks we had over here, but I think that we're at the end of our time, and so grab us independently and we'll respond to your queries. But thanks, gentlemen, for your time and preparation.